Now, last but not least, Philippe Garot about the left atrial closure device. Where are we now?
Thank you very much, Mohammed. Can you hear me?
Yes, but you need to see your slides.
Yeah. Can you see my slides?
Yes,
Yes.
okay, go ahead.
So, yes, for this last presentation, the question in this structural session, the question is left atrial appendage closure, where are we now? And as you know, the vast majority of strokes in patients with AF is caused. I'm not in full screen. Okay. Is it okay? Yes, thank you. So the vast majority of patients with stroke in AF are because of a clot that forms in the left atrial appendage. You can see an example on this echocardiography view of the appendage. And this clot may dislodge and go anywhere in the arterial system, and of course, especially in the brain. So you know that the SHATS-VASc2 is the gold standard to evaluate and to anticipate the risk of stroke in these patients. You have here on this slide the parameters that are used in the SHATS-VASc2, and you can see here that the risk of stroke, annual risk of stroke, is growing when the scores goes from 0 to 9, from 0 to 15, and sometimes more % rate of stroke per year. And very importantly, in the last guidelines, we have learned that the treatment, anticoagulant treatment, should be considered in patients with the SHATS-VASc from 1 and above, of course. So we have to treat patients at risk of stroke, and we have to treat patients with atrial fibrillation. Unfortunately, we know that patients are not really adherent to drugs and to anticoagulants. And this is a paper from Yao, and you see that this paper is from a survey with a large number of patients, 64,000 of patients. And you can see that even in the era of NOACs, the adherence of patients to drug is no more than 50%, 40 to 60%. That means that many patients should be treated with anticoagulants, but they don't take. So in this setting, we know about left atrial appendage closure. It's a strategy that consists in closing the appendage in order to avoid the risk of systemic embolism. And this is the main trial, PROTECT AF trial, that has been done in 2007. And this trial showed that the strategy of left atrial appendage closure is non-inferior to compared to anticoagulants in protecting from stroke in non-selected patients with AF. And you can see that up to 5 years, we had the good news of this paper that the strategy of closing the appendage could be better in terms of superiority in all-cause mortality. So this trial is really a cornerstone, and it makes the techniques start and grows. But we are still in the beginning of the strategy, and this is why this presentation, where are we now? So why are we not growing as TAVI or other techniques? Maybe because of risks, but no, as you can see on these slides, the risk of the strategy are not so numerous, not so important. You can see here, before the clinical experience, this was the time of PROTECT. We had some, yes, some pericardial tamponade, some strokes, some embolization. It was something like 4 to 2%. But today, in the recent era, we have really few adverse events, and the technique is really, really safe, and it's no more a problem. Is it a problem of costs? No, because the technique is cost effective. You can see here the technique, invasive technique in blue, and you can see here the treatment with NOAC and treatment with warfarin here. You can see that the technique is cost effective versus NOAC at year 4 and versus warfarin at year 8 or 9. So the problem is not a problem of safety, it's not a problem of cost. So where's the problem? We had a lot of these devices, you can see here, and many, many more. Today we are using in the vast majority everywhere in the world 2 devices, the Amulet from the ABOT on the left panel. The CE mark is on the good way to become FDA approved, and the Watchman Flex is the new generation of Watchman that is FDA approved and CE mark as well. This is the procedure you can see here. So how to go into the appendage, the technique is to go through a transeptal punction. You will see here, the transeptal punction is performed in a posterior and inferior way in order to be well aligned to the appendage. You can see here the catheter coming just in front of the appendage, and it's very important to be well aligned and to have no angle between the device, the loader, the catheter and the appendage. This is the ostium of the appendage, and you are going to wire the appendage very carefully and to go with the catheter. Here is the catheter coming inside the appendage. This is the moment that you have to take care, a lot of care, not hurting the appendage. That is a very, very fragile structure. Then you push and open, not push, but first you unsheath and open the lobe, and you place the lobe in the proximal part of the appendage, and this is the second point. You unsheath again and place the disc on the ostium of the appendage. And then you have to check with 3D TOE and see if the sealing is okay, and when everything is okay, you can release the device inside the left atrium. So really, we have learned a lot from last year's in how to guide these procedures. We are using a lot of imaging multimodalities to guide the procedures. We use CT for planning. It's really a good tool, as we do for TAVI, as we do for a lot of structural heart strategies. CT is really nice to first rule out the presence of thrombus, and then to define the measurements of the appendage and see if the patient is eligible for the technique. For live imaging and guidance, we use TOE. We have used in some patient eyes, and we are more and more frequently using the fusion of different imaging modalities like CT and angio, TOE and angio. We are also using some simulation, preoperative simulation, to anticipate what could be the result if we use this or this device, this or this size, this or this positioning. And we have used in some selected cases 3D printing. So this is an example of a patient, and this is the possibility we can have with MSCT. You see that MSCT is very good for sizing. We have some underestimation. With TOE, we can rule out the presence of thrombus, and we can use the CT of the patient for patient-specific computer simulation. We also use this for per procedural guidance, because we're using MSCT on the angio. I will show you a case, and in some patients we have used for 3D printing. This is the computer simulation. We are using the FEOPS technology, which is a Belgium company, and you see the principle of the technique is to use the 3D computer model of the LAA of the patient with pre-procedural CT scan, and we are, not we, but the engineers are putting inside the model of the patient the 3D computer model of LAA closure device, which takes care into account the mechanical properties and behavior of the device. And then you have a prediction of how the device morphology and function could behave using physics-based simulation inside the appendage. And this is an example you see here. We have angio, we have the catheter, we have the device that is already in place in the appendage. We also have the TOE probe, and we have in red the contours of the left atrium with the appendage, and in yellow you have how the contours of the device, how it was simulated. So we are using the FEOPS, compression parameters, positioning, and we put that onto our screen, a flat, large screen display, and then we try to go at the good position. And you can see here an example, which is not so good. The lobe and the disc are well aligned in a good position inside the appendage. So the technique is now being routinely used in some countries. You see that it started in 2005, and today we have over 60,000 implantations around the world, but it's still largely underused with regard to the very, very high number of patients with atrial fibrillation and with regard to other structural heart techniques like TAVI. So why don't we use it more? As I said, non-valvular AF is a very, very frequent condition, especially in elderly patients. We have seen that the adherence to anticoagulants is very poor, even in the era of NOACs. And we know now that LAA closure is efficient and a safe strategy. So why don't we close more? We do not have very supportive guidelines. And why this? Because we are missing large trials. We are clearly missing large trials. As I told you, the PROTECT AF is an old study now. It was done in 2007. PREVAIL was done in 2010. And we have really old data, a lot of registries, a lot of series, but nothing was randomized in the last 10 years. So these are the guidelines you can see here, the ESC guidelines on the left panel and American guidelines on the right, and we have exactly the same graduation. It's a class 2B, level of evidence B, and you see that LAA occlusion could be considered for stroke prevention in patients with atrial fibrillation and contraindications for long-term anticoagulant treatment. Exactly the same in both guidelines. And very interestingly, we can say that the guidelines propose this in these patients, but the techniques has not been evaluated in these patients because PROTECT and PREVAIL were randomized in patients eligible for both techniques, LAA closure, but also for anticoagulants. So we are using this in a population where we don't have any option, but we don't have the proof that the technique is effective in this population. If you see here the past ESC guidelines for LAA closure, you see in 2012, it was exactly the same, contraindication for long-term oral anticoagulation. And in 2016 was exactly the same, a little bit stronger with those with a previous life-threatening bleed without a reversible cause. We see that we do not have done any progress in the last 10 years. This is the current status in France. You see here that we have in France per year approximately 30,000 hospitalizations for bleeding, severe bleedings under vitamin K antagonists. And the estimation by the healthcare authorities was that approximately 1/3 of them could be treated with LAA closure. And you see that we had reimbursement 5 years ago, and we were at that time at 1,200 procedures for the whole country. And today we are still around 2,000 cases. We were at 180 in 2017, and today In 2020, it was less because of the pandemic, but in 2019, we were around 2,500 cases. So this is the Catalyst trial. This is, I told you that we are missing large trials versus no modern treatment that are NOACs, and we have very good news that we are starting 2 trials with the 2 main devices. This is the Catalyst trial with from the Abbott company, the sponsor of the trial, with the Amplatzer amulet. You see this clinical trial is a randomized trial of amulet versus NOACs. The target is to randomize 2,650 patients 1-to-1, and the study has started in 2020, in July. End of recruitment is scheduled to be in December 2024. And you see the primary endpoint is a composite of ischemic stroke, systemic embolism, and cardiovascular mortality at 2 years. And the randomization and the statistics will be done for non-inferiority of the device against NOACs for this. The second primary endpoint will be a safety primary endpoint, like major bleeding or clinically relevant non-major bleeding events, excluding procedural related events at 2 years. And for this, the superiority will be tested of the device versus the drugs. We have exactly or quite exactly the same trial with Boston. This is the Champion AF trial with the Watchman Flex. You see here the clinical trial is a comparison of Watchman Flex versus NOACs, 3,000 patients, randomization 1-to-1. It started in October, 3 months later. End of recruitment will be in December 2025. And you see that the primary endpoint is exactly the same, non-inferiority for ischemia and superiority for bleeding. But the time frame will be 3 years, whereas it's 2 years for the Catalyst trial. So my conclusion, dear colleagues, is that where are we with left atrial appendage closure? We have learned a lot. We can do that. We can make it efficient and safe, but we are clearly at a corner. The point is that it's an efficient procedure. We know that we can prevent ischemic stroke in patients with non-valvular AF and to prevent from bleeding thanks to anticoagulant discontinuation. We have a lot of data derived from very old trials, and we are missing that new data. So guidelines are still not very supportive, but we hold hope that we will have evidence from Catalyst and Champion in 3-4 years, and that it would be a good signal for expanding indications. Otherwise, I guess these techniques will remain a niche strategy in very highly selected patients, just because we don't have any option. Thank you very much for your...
Philippe, thank you very much, Philippe. You tell the truth. Actually, I started to do this 8 years ago, but I stopped since the beginning of NOAC and just adjusting the dose according to the guidelines in NOAC with the age, body weight, and creatinine clearance, and so on. So I think, and also it's doubling the price here in Egypt, and no reimbursement. That's why it stopped. But my question to you, do you do a CT for before doing Watchman device or amulet regarding the size of the left appendage, or the, you know, that there are different shapes, and what is the shape which is not allowed you to deploy this kind of device?
Of the Watchman?
Yes.
I mean, we are doing CT for all patients, except in those with very severe renal failure. And I have to say that probably 85 to 90% of appendages could be closed with both devices. We used to select short neck devices for the amulet because the Watchman in the old version was a little bit dangerous because of the the foots of the watchman that could be hurting the deep part of the appendage. But today uh, with the flex version, we don't have this limitation. So for me, we don't have any difficulties today to treat the vast majority of patients with both devices.
Question to Khalid.
Yes, thank you, Philip, very much. You told us great news that we are waiting for 2 ongoing trials comparing NOACs with the 2 devices, Champion and Catalyst. Would you please tell us if you know more details according to inclusion criteria, namely risk profile, CHA2DS2-VASc of patients in the inclusion criteria of 2 trials?
Yes, it's absolutely important to see that. And for both trials, the risk is selected above CHA2DS2-VASc 3. So 3 and more, and no contraindication to anticoagulants, eligible for structural procedure, I mean no allergy or nothing special. And then you can be enrolled in the trial and you will be randomized 1-to-1 for device or drug. But it's above CHA2DS2-VASc 3.
Okay, any question, Dr. Any?
Thank you very much. Just a small question. What about anticoagulation after this device? Because we saw 1 or 2 patients with some thrombus on the device itself.
Very, very important question. Thank you for asking. In the first trial in PROTECT, patients should be treated for 6 weeks with warfarin after the procedure. But in the recent era, more and more registries showed that DAPT for 6 weeks to 3 months, followed by single antiplatelet therapy, is probably enough. And in some patients, about 25% of our population, we didn't use any antiplatelet drugs because of active bleeding. Some of patients have intracranial active bleeding and we can't give them anything. So in some of these patients, we are just putting the device and leave them away with some TOE or CT control. And we had very, very few rates of thrombosis. So the question about the risk of device-related thrombosis, we know it's about 5 to 7% in general. I think it depends on the technique and depends on how and where you put the device.
Thank you very much. I think we come to the end now. We have 2 days, fruitful days, thanks to the Pariseed group with the CVREP foundations, the champs. Actually, we enjoyed the lectures. We have 2 days about ischemia trials, calcified lesions, instant restenosis, CTOs, all types of bifurcations. And even we have 2 live in a box complex bifurcations and also calcified lesions. And today we have non-invasive imaging, CT, multi-site CT, MRI intervention, which is future intervention, and finally structural heart disease regarding TAVI with a live in a box, mitral clip, tricuspid, and then left atrial closure device. I think we with a live in a box. I think we with all this interaction, even in hybrid model, we succeeded with all national faculty. And thanks to Pariseed Group, I'm going to thank all of you again by name. If you allow me, thanks to Antoinette, Bernard Chevalier, Francesco, Hakim, Bernard, Germain Garot, Philippe Garot, Thierry Telefevre, and Thomas Servav. Thank you, all of you, for doing a great job with us. And thanks to the national faculty. Now the word for you, Philippe. Are you with us, Philippe?
Thank you very much, and you are always welcome. And I hope to meet you next year in person and not with the visio as we do today. But thank you so much, and see you soon. Thank you.
See you soon after vaccination. Okay.
Absolutely.
Bye-bye.
Bye-bye.